is another set. So first question is, which of the following instructions should be provided to a patient receiving fentanyl transdermal patches? A. Apply on area with fresh food. B. Avoid increase in body core temperature. C. Store patches in the refrigerator to decrease stinging sensation. D. To apply heating pads on the transdermal patch to improve absorption. So which one is the instruction given to the patient?
Option D, ma'am.
Option D, applying heating pads will increase the absorption of drug, so that can
No.
cause toxicity. Okay, so
Yeah.
the correct answer is option B, avoid increase in body core temperature. If the body temperature or any heat is applied, or when the patient is exposed to sunlight for a long period of time, that can increase the absorption of fentanyl from the patches, and that can cause toxicity. So you should not apply heating pads, or you should not expose to sunlight for a long period of time, or you should not increase the body core temperature. That will cause toxicity. So the advice given is avoid body core temperature. Okay. And applying on area with fresh food, the transdermal patches is not applied on the area which is having fresh food. It should be not placed on fresh wood, and no need to store in a refrigerator. Okay, you can store in normal room temperature, no need to store in a refrigerator. So the advice or instruction given to the patient is avoid increase in body core temperature. Next question. A 55-year-old man with African descent is diagnosed with hypertension with a BP of 140/80. Which of the following is the most appropriate first-line treatment? So most appropriate first-line treatment for the African descent. Ramipril, amlodipine, carvedilol, candesartan. Which one is the first line? Amlodipine. Option B, amlodipine is the correct answer. For African descent or black patients, the drug of choice is calcium channel blocker, or for the black patients. Okay, so black patients are low renin responders. So if we are giving any drug that is acting on renin angiotensin system, RAS, that is having less effect, because the African descent or black patients are low renin responders. So we cannot give AC inhibitors or ARBs as a monotherapy for that patients, black patients. So
only
the
for
drug of
Africans, ma'am,
choice
or
is
Indian? Ma'am, only for Africans,
so,
this valid for?
yes, African descent, like black patients.
Indian black, what about Indian black patient? We can follow the same.
That is not an issue. Mainly black patient, Indian black is not that much black as Africans, right?
Yeah.
Mainly the
Right.
African descent is low renin responders. Okay. So for black,
Okay, understand.
the drug of choice is calcium channel blocker or the thiazide diuretics. So for normal patients, we can use AC inhibitors or ARBs. For that patient, we can use AC inhibitors or ARBs, and calcium channel blocker or thiazide diuretics are used as the first line treatment. So for African descent, it is amlodipine. Ramipril is an AC inhibitor, candesartan ARB. This cannot be used as a monotherapy, and carvedilol is not the first line drug. So amlodipine, calcium channel blocker, is the first line drug. So next question is, a diabetic patient on metformin, pioglitazone and sitagliptin screening shows positive hepatitis C and elevated liver enzyme. What is the most appropriate action? A. Do not change the medication. B. Stop pioglitazone. C. Stop sitagliptin. D. Stop pioglitazone and sitagliptin. So if hepatitis C and liver enzymes are elevated, what is the appropriate action? So here actually option B. Option B is the correct answer. What is the area of pioglitazone? Is it causing hepatotoxicity? Pioglitazone.
Yes, ma'am. Yes, it's causing.
Yes, pioglitazone is causing hepatotoxicity. So if patient taking pioglitazone is having positive hepatitis C and elevated liver enzyme, that can increase the risk of hepatotoxicity. So the patient should stop pioglitazone. No need to stop sitagliptin. Both drug has not no need to be stopped, because sitagliptin is not causing hepatotoxicity. Only pioglitazone is causing. So we can continue sitagliptin and stop pioglitazone. Okay, as pioglitazone is having hepatotoxicity. Next question. A physician is asking pharmacist about the effect of low albumin and acute renal failure on phenytoin serum concentration. Patient is receiving phenytoin 300 mg once daily. What should be the most appropriate suggestion? That is effect of phenytoin on low albumin or acute renal failure patients. So option A, in hypoalbuminemia and acute renal failure, obtain free phenytoin serum concentration. Option B, obtain peak phenytoin serum concentration. Option C, obtain total phenytoin serum concentration. And option D, obtain trough phenytoin serum concentration. So what will be the answer in low albumin and acute renal failure? What has to be checked for phenytoin? Is it free phenytoin, total phenytoin, or trough phenytoin? So what we are checking the phenytoin concentration. We have discussed the equation for finding the corrected phenytoin level, right? In the general pharmacology portion. You remember that one? In general pharmacology portion, we have studied the equation for finding corrected phenytoin level.
No, ma'am.
Remember?
Don't remember.
Corrected phenytoin level is right? So patient with low albumin or acute renal failure, we will be checking free concentration because we know that phenytoin is a highly protein bounded drug. So it is mainly binding to albumin. Is having acute renal failure, the amount of phenytoin that is bounding to the albumin will be low. That is phenytoin in the body. And unbound phenytoin or unbound form of drug is producing pharmacological effect or it is producing toxicity. So if so, we have to check unbound form. We know that while plasma protein bounding, the bound form, the unbound form of drug is producing pharmacological effect. If the unbound form of drug is more, it can cause toxicity. Okay, so we have to find how much drug is unbound and we have to reduce the dose according to that one. So for finding only the unbound form of drug, we can obtain the free phenytoin serum concentration. Okay, we have already studied the equation for finding free phenytoin concentration. So if the patient is having low albumin level, find free phenytoin concentration. Okay, by the equation you can find the corrected phenytoin or free phenytoin concentration, and that will give the amount of unbounded phenytoin. Only the unbounded phenytoin we can obtain by free phenytoin serum concentration. And if we are obtaining total phenytoin concentration, there will be the concentration of bound phenytoin and unbound phenytoin. Both will be obtained by total phenytoin. We only need how much is unbounded. So for finding unbounded only, we can do the free phenytoin concentration. In the total phenytoin concentration, there will be bound and unbound concentration. So no need to get total phenytoin, only free phenytoin is necessary. And about peak concentration and trough concentration, when we are collecting the trough level samples will be collecting half an hour before the next scheduled dose. Okay, so before the next dose, half an hour before the next dose, we will be collecting the trough level samples. For the narrow therapeutic index drug, most frequently we will be collecting trough level concentration. For more drug, we will be using trough level concentration. And for obtaining peak level concentration, we will be collecting the samples after 1 hour of administration. So after administering the drug, after 1 hour, we will be collecting peak level samples. Peak level means the amount of drug that is present after the administration. So after 1 hour of administration, we will be collecting the peak level samples. And trough level is 30 minutes before next scheduled dose. Okay. Next question, a 6-year-old boy is brought with complaint of uncontrollable spasm-like movements and excessive eye blinking for 4 months. chronic motor disorder is diagnosed? Which of the following is the best management? Pregabalin, haloperidol, methadone, chlorzoxazone. Which one is the drug for chronic motor disorder?
Haloperidol.
Yes, option B, haloperidol. It is an antipsychotic drug. It is used for the treatment of chronic motor disorder. It is mainly having the mechanism by blocking the dopamine receptor, and that will reduce the frequency of excessive movements. Okay, so for treatment of chronic motor disorder, we are using haloperidol. In the file, it is given as chlorzoxazone. Chlorzoxazone is not the answer. Chlorzoxazone is a muscle relaxant. Mainly for treating chronic motor disorder, haloperidol is used. Okay, it is an antipsychotic drug. By blocking dopamine receptor, it will reduce the excessive movements and it will treat chronic motor disorder. So you have to correct the answer. In the file, it is given as option D, chlorzoxazone. It is not the correct answer. Option B is the correct answer. Which of the following could lead to decrease in international normalization ratio in a patient with warfarin therapy? Decrease the consumption of dietary vitamin K, carbamazepine therapy, cotrimoxazole therapy, metronidazole therapy. Which one will decrease the INR?
Option A, ma'am.
Option A, vitamin K. Decreased consumption of vitamin K will decrease the INR. What is vitamin K?
No, ma'am. Actually,
Okay,
option
what is...
B, ma'am.
Yes, correct answer is option B. Carbamazepine therapy. That is the correct answer. So what is vitamin K? Vitamin K is the...
Coagulant.
Vitamin K will reverse the effect of warfarin, right? So vitamin K
Yes,
will reduce the warfarin level. So if we decrease the consumption of vitamin K, it can increase the warfarin, the INR. Okay, vitamin K will reduce the INR, but decreasing the consumption of dietary vitamin K can increase the INR. Okay, and here carbamazepine, cotrimoxazole, metronidazole. Among these three therapy, carbamazepine is the correct answer. What is the reason? How this
inducer, ma'am. Enzyme
which,
inducer.
yes, it is an enzyme inducer. Carbamazepine is an enzyme inducer that will increase the metabolism of warfarin and will reduce warfarin level and reduce the INR. Okay, so all the enzyme inducers will reduce INR by rapidly metabolizing the warfarin. And about cotrimoxazole and metronidazole, what are they? They are enzyme inhibitors that will inhibit the warfarin metabolism and that will increase the INR. Okay, so enzyme inducers will reduce the INR and enzyme inhibitors will increase the INR. Okay, and here vitamin K will decrease the INR, and if we reduce the dietary vitamin K, that can increase the INR. Next question. A 62-year-old male taking warfarin for stroke prevention in atrial fibrillation present to his primary care physician with an elevated INR of 10.5 without bleeding. He is instructed to halt the warfarin dose and given 2.5 mg of oral vitamin K1. When would the effect of vitamin K on the INR most likely to be noted in this patient? So when will the vitamin K produce the action? That is the question. So 1 hour, 6 hour, 24 hour, 72 hour. So how long it will take to produce the effect, vitamin K? Option C, 24 hours is the correct answer. Okay, 24 hour, it is the time required to synthesize new coagulation factors. This vitamin K, it is having delayed onset of action. So it will take some time for producing effect. And this 24 hour is a standard time for the production of new coagulation factors. The new coagulation factors will be producing within this 24 hours. So 24 hours is required for reversing the warfarin effect by vitamin K. Next question. A 80-year-old patient with asthma and low blood pressure requires anesthesia for an emergency surgical procedure. Which of the following agent would be most appropriate for inducing anesthesia in this patient? The patient is having asthma and low blood pressure. Which is the most appropriate anesthetic? Desflurane, ketamine, propofol, thiopental. Which one is the correct answer? The drug should not
Propofol.
worsen the asthma and hypotension.
Propofol, ma'am. Option C.
Propofol is actually propofol is causing low blood pressure. Propofol can
Oh.
reduce the blood pressure. So here patient is already having low BP. So it is not given for the patient. So the drug should be safe in asthma. Okay. So the drug which is having bronchodilation effect and the drug that is not lowering the blood pressure. Most of the anesthetics are causing low BP. Causing low BP here. Option B, ketamine is the correct answer. Actually, this ketamine is having bronchodilator effect. So it is safe in asthma patient and ketamine is not reducing the blood pressure. So it is safe for patient who is already having low BP. Other drugs, desflurane, propofol, thiopental, these three drugs are reducing the blood pressure. So it is not given for a patient who is already having hypotension. Next question. For a drug with pKa of 3.5, which pH value would be most suitable to maximize its solubility? So water solubility is increased in which pH for a drug with pKa 3.5? pH 9, 4, 3, 2. At which pH the drug will be having maximum solubility? The correct answer. So about this pH and pKa. What is this pKa? pKa is the acid dissociative constant. So the pH at which 50% of drug is ionized and 50% of drug is unionized. That is pKa. So for a drug to be have more absorption, which form of drug will be having more absorption, ionized or unionized? Which will be more absorbed?
Unionized form.
Yes, unionized non-polar drug will be having more absorption and ionized polar drug will be eliminated easily. Okay, so for a drug which is having, the pH that is lower than pKa, okay, pH lower than pKa, the drug will be unionized form and less soluble. Okay, so the pKa, here the pKa is 3.5. So the pH below 3.5, the drug will be unionized form. So it is more absorption and it is less water soluble. Water soluble means the drug should be in ionized form. So the pH lower than pK and it will be having less solubility. And pH greater than pKa, that is above 3.5, the drug will be ionized and that will be having more water solubility. So ionized form of drug will be more water soluble and it will be easily eliminated. Here the pKa is 3.5. So pH lower than 3.5, the drug is unionized form and it is less soluble, and the pH above 3.5, that is 4 and 9. Among these 4, it is slightly greater than 3.5. So the max solubility is not maximum. At pH 9, it is higher than, that pH is higher than pKa. So it will be having maximum solubility. At pH 9, it is in ionized form. So it will be having maximum water solubility. And this pH 3 and 2, it is lower than pKa. In this pH, the drug will be existing in unionized form. Okay. So always remember these 2 points. For a weak acid, the pH lower than pKa, the drug is in unionized form, and pH higher than pKa, the drug is in ionized form.
Yes, ma'am.
Is that clear? Next question. A patient has COPD and FEV1 is less than 75%. What is the gold criteria? Here, gold classification of COPD. It is an important, this one is important question about the gold classification of COPD. The patient is having COPD and FEV1 is less than 75%. the patient belongs to gold 1, gold 2, gold 3 or gold 4. Okay, this is the gold classification of COPD. Now the gold classification of COPD question is not included in the regular class, so we can discuss it here. Okay, this is the gold classification. Gold classification of COPD is based on the severity of COPD. According to the severity of COPD, the patient is categorized into 4 stages, that is stage 1, stage 2, stage 3 and stage 4. Stage 1 is mild condition, stage 2 is moderate condition, stage 3 is severe and stage 4 is very severe. Okay, and this one is assessing by by spirometric test. We will be assessing the patient's FEV1 and FVC. FEV1 is the forced expiratory volume in 1 second. Okay, forced expiratory volume in 1 second means the volume of air a person can forcefully exhale in the first second. Volume of air the patient can forcefully exhale in the first second, that is forced expiratory volume in 1 second. That is assessing by spirometry test, and we can assess the FVC also. FVC is the forced vital capacity. Forced vital capacity means total how much volume of air a patient can forcefully exhale. So forcefully exhalation of the full volume of air, that is forced vital capacity. So these two are monitored by the spirometric test and we can categorize the gold classification. So for gold classification, we will be assessing the FEV1 percentage and FEV1 FVC ratio. So the forced expiratory volume in first second and forced vital capacity ratio be assessing. So for a patient with a COPD, the FEV1 FVC ratio will be always less than 70%. Less than 70% or 0.7. Less than 0.7. Any patient who is having COPD, the FEV1 FVC ratio will be always less than 70% or 0.7. Okay. Only change in FEV1 percentage. Okay. So you have to study the change in FEV1 according to each stages. So for mild condition, the FEV1 will be always greater than 80%. So for moderate condition, FEV1 is 52%. For severe condition, it is 50% and 30%. So here the patient's FEV1 was which class this patient belongs to. If the patient's FEV1 is 75%, which class the patient belongs to?
3, ma'am.
Is it 3? 75%, 50 to 80. 75
No,
is
sorry, it's
in
2.
between.
Gold standard
Okay.
2, ma'am.
2, ma'am.
Gold 2 is the correct answer. If it is 45, how much the patient belongs to? If it is 45.
3.
3, ma'am.
50 to 8. 2 is 3 and 30 is you have to study. Okay. So COPD. Is that clear? Important. There will be question from next question is the severity in patient who experiences symptoms 2 days per week with no exercise limitation and FEV1 is greater than 85%. So this question is based on the severity of asthma. Okay, based on severity of asthma, the patient is having the symptoms 2 days per week with no exercise limitations and FEV1 is greater than 85%. So is it intermittent asthma, mild asthma, moderate asthma, severe asthma? In which severity it belongs to? It is based on the severity of asthma. For that also we are having classification. The chart is there based on the asthma severity. The patient is classified into intermittent asthma, persistent, moderate persistent, severe persistent. Okay. And the factors we are checking is daytime symptoms, nighttime symptoms, rescue inhaler use, exercise limitation, FEV1 and FEV1 FVC ratio. By checking these factors, we can classify the patients into 4. Okay. So for intermittent asthma, the daytime symptoms will be less than or equal to 2 days per week. In a week, less than or equal to 2 days, the patient will be having daytime symptoms. So it is a starting stage. Nighttime symptoms means in a month, it will be less than or equal to 2 times. The patient will be having nighttime symptoms in a month. And rescue inhalers for the in a week, only less than 2 days, the patient will be using inhalers. And there is no exercise limitations. Exercise limitation is none. And FEV1 is greater than 80% and FEV1 FVC ratio is greater than 85%. And risk means the use of oral steroids. In a year, the patient will use 0 to 1 oral steroids. If this is the condition of a patient, the patient is classified into intermittent asthma. Okay, less than or equal to 2 days per week daytime symptoms, less than or equal to 2 times per month nighttime symptoms, rescue inhaler use, that is less than or equal to 2 days per week, no exercise limitation, 0 to 1 oral steroids per year means the patient is intermittent asthma. Okay, so here in the question it is given as the symptoms 2 days per week. Only 2 days per week the patient is having symptoms with no exercise limitations. FEV1 is greater than 85%. So FEV1 greater than 85%, no exercise limitations, 2 week symptoms. That means the patient belongs to intermittent asthma. Okay, like that. The patient's condition will be given and you have to identify the patient belongs to which class. Intermittent asthma here. So this intermittent is clear?
Yes, ma'am.
Yes, ma'am.
Okay, like that we can discuss mild. In case of mild persistent, the symptoms is, the severity is increasing when combined moderate and severe. Okay, so in daytime symptoms greater than 2 days per week. If the patient is having the daytime symptoms greater than 2 days in a week, it is mild persistent. And nighttime symptoms, it is 3 to 4 times per month. More than 2 times or 3 to 4 times per month, the nighttime symptoms means it is mild persistent. And rescue inhaler use. The patient will be using inhaler for more than 2 days in a week. Less than 2 days means it is intermittent. More than 2 days in a week means it is mild persistent. And there will be minor exercise limitations. FEV1 and FEV1 FVC ratio is greater than 80%. In case of mild persistent. In case of moderate persistent, we having daytime symptoms, nighttime symptoms per week. It is in per week. Moderate means per week, more than 1 time the patient will be having. Persistent, it is in month, per month, but in moderate persistent, it is 1 time there will be nighttime symptoms. Daily the patient will be using inhalers. Patient using limitations. FEV1 is 60 to 80, FEV1 FVC ratio is 75 to 80%. And in severe persistent, daytime symptoms, throughout the day, the patient will be having several times in a day, the patient will be using inhalers. The exercise limitations, it is extremely limited. All the activities will be extremely limited. And FEV1 is less than 60, FEV1 FVC ratio is less than 75. And in these 3 cases, mild, moderate and severe condition, the patient will be using more than 2 oral steroids per year. So, for example, if the question is, the patient is having daily daytime symptoms with some exercise limitations and the patient is using inhalers almost all day, that means The patient belongs to which class? Daily the patient will be having symptoms, and almost all day the patient will be using inhalers and with some exercise limitations.
Moderate persistent, ma'am.
Yes, moderate persistent. Like that questions will be asking. So you have to check the symptoms of the patient and you have to study this based on the symptoms. How can we classify? This one you have to study properly. Okay. So this COPD classification, that is GOLD classification, and asthma severity classification is important. It is not included in the recorded session. So you have to study from this class. Okay. So this one is very, very important. Clear? Next question. A 60-year-old female patient started on a new antihypertensive drug recently. Her blood pressure seems to be under control, but she complains of fatigue, drowsiness, and fainting when she gets up from the bed. That is orthostatic hypotension. Which of the following drug is she most likely taking? So, which one causes orthostatic hypotension? Metoprolol, propranolol, prazosin, clonidine. Which one is having orthostatic hypotension as the side effect?
Ma'am, prazosin.
Yes, prazosin. Prazosin is a alpha 1 blocker. It is having static hypotension, drowsiness, fatigue as the side effect. Okay, remaining drugs: metoprolol, propranolol, clonidine. It can cause drowsiness, but orthostatic hypotension is specific for prazosin. Next question. A physician prescribed heparin at a dose of 75 units per kg every 6 hours for a child weighing 15 kg. Heparin is available in 2.5 ml in 2500 units. How many milliliters of heparin should be administered every day? Every day, how many milliliters of heparin is administered from this 2.5 ml vial? Okay. So what is the dose that is given for this 15 kg weight patient? How can we find the date for every day? So you have to find the per day dose for the patient who is having 15 kg weight. So how can we find the dose?
15 into 75 into 6, ma'am.
75 multiplied by 4 into 15.
Yes. 75. 75 is the units that is given per kg. So 75 into 15 is the weight into per day. How many times it is administered?
Four times, ma'am.
4 times,
4
ma'am.
times. Okay. You should not multiply with 6. It is 6 every 6 hours means in 24 hours it is given 4 times. Okay. So 75 into 15 into 4. The answer is 4500. 4500 unit is given per day. Okay. So per day the patient should get 4500 units. And here the heparin is available in 2 ml. Okay. In 2.5 ml, how much unit is there? 12,500 unit is there. Okay. So in how much ml this 4500 unit is present? That one you have to find. How much ml? So how much ml is given per day? That one you have to find by multiplication. 2.5 ml contains 12,500. So how much ml is containing 4,500 units? So by cross multiplication, 2.5 into 4,500 divided by 12,500. So answer is 0.10. 0.9 ml is given per day. Okay. If it is per dose, no need to multiply with this 4. Only 75 into 50 per dose. So you have to check every time, is it for per dose or per day? You have to find. If it is per day, you have to multiply with how many times it is given. And for per dose means just multiply with units into weight. Okay. So here 0.9 ml is the correct answer. Is that clear? Next question is, Which of the following antibiotics should be avoided in a patient with history of myasthenia gravis due to worsening muscle weakness? Azithromycin, amoxicillin, levofloxacin, doxycycline, which can worsen the myasthenia gravis condition. So, which is avoided in myasthenia gravis patients? What is myasthenia?
Levofloxacin, ma'am.
Yes, levofloxacin is the correct answer. So, what is myasthenia gravis? Well, it is causing muscle degeneration, muscle weakness. So, the drugs that is causing muscle weakness or neuromuscular
Yeah.
blocking, neuromuscular weakness should be avoided in patient with myasthenia gravis. So, here levofloxacin is causing the muscle weakness. So, it is avoided in patient with myasthenia gravis. The most
Yeah,
risk causing
because
drug is
levofloxacin may cause tendinitis also, ma'am. I answered because of tendinitis.
yes. And in this case, the most risk causing drug is aminoglycosides. Okay.
Yes.
Aminoglycosides. If any option is aminoglycoside, you should choose that as the correct answer because aminoglycosides are causing more risk of muscle weakness. So it is avoided in myasthenia gravis. So the first risk causing drug is aminoglycosides. After that, it is levofloxacin. And if these two drugs are not given, we can choose azithromycin, macrolide antibiotics. Glycosides, fluoroquinolones, or macrolide antibiotics. These are causing muscle, worsening the muscle weakness, and more risk is for aminoglycosides. After that, it is levofloxacin, and after that, it is macrolide antibiotics. Okay. So, if in the option aminoglycoside is given, you should choose that one. Otherwise, you can go for levofloxacin. If these two drugs are not given, you can choose azithromycin. Okay.
Okay, ma'am.
This is not worsening the condition. It can be given. Next question. The organization that evaluates pharmacies to make sure they are following all appropriate professional standard is called Joint Commission or the Food and Drug Administration or the Department of Health and Human Services or National Institute for evaluating the pharmacies to make sure they are following all the professional standards. All the
Option
healthcare
A, ma'am.
organizations are following professional standards. It is evaluated by
FDA, ma'am. B.
FDA is mainly ensuring the safety and efficacy of drug, not related to pharmacy. FDA is related to assessing the
Safety of the
ensuring
drug.
the safety of food and drug. Okay, here the organization that evaluates pharmacies or healthcare in healthcare organizations that are following proper standards, professional standards. Who is evaluating that one? The answer is option A, Joint Commission. Okay, Joint Commission, they mainly accredit the health and ensure the safety standards of or the healthcare institute. Pharmacy related standards are evaluated by Joint Commission. And and Department of Health and Human Services, they mainly focus on the they mainly organize the health programs organized by the Department of Health and Human Services. And National Institute of Health, they mainly focus on funding for clinical studies. Fund of clinical studies are done by the National Institute of Health. So mainly assessing or follow making sure or evaluating the pharmacist, sorry, not the pharmacist, pharmacies or healthcare organization, they are following professional standards. It is evaluated by Joint Commission. Okay, like that. Another question, that is, which of the following organization established many of the professional standards for pharmacist? For pharmacist, the professional standards are set by Board of Pharmacy, Food and Drug Administration, Department of Health and Human Services, National Institute of Health. Which one is establishing the professional standard for pharmacist? These three options we have already discussed. Is the answer? These three options can be the answer.
Department of Health and option C.
Department of Health and Human Services mainly organize health programs. They organize health programs. The question is, who established the standards for pharmacists? Professional standards for pharmacists. We know that option D, NIH is focusing on funding of clinical trials, and Department of Health and Human Services is focusing on organizing health programs. FDA is focusing on the safety and efficacy of food and drug. So these three are not the answer. The answer is Board of Pharmacy. Every state will be having its own Board of Pharmacy. Will be setting the professional standard for pharmacists. They will be accrediting, or they will be giving license for the pharmacist. They will be conducting the licensing exam for the pharmacist. Okay. So the standards to pharmacist, it is established by pharmacy. The standards that is specific to pharmacy, it is organized by Joint Commission. Next question. Which unexpected medication might you find could interact with the diltiazem, potentially altering its effectiveness or causing side effect? Amlodipine, verapamil, atenolol, nifedipine, which can interact with the diltiazem and alter its effectiveness or cause side effect? Diltiazem will interact with amlodipine or verapamil or atenolol or nifedipine.
Option B, ma'am. It's looking different from calcium channel blockers.
Option B.
Option B.
Verapamil is the correct answer. So what is the reason? Diltiazem and verapamil belongs to same class. That is calcium channel blocker, non-dihydropyridine calcium channel blocker. So this is belonging to same class of drug. So it will exaggerate the effect and it can cause severe hypotension. Okay. So
Yes.
as it is belonging to same class of drug, that is non-dihydropyridine calcium channel blocker, it is having the most nifedipine. These it is dihydropyridine calcium channel blocker. Okay, dihydropyridine calcium channel blocker, and this verapamil is non-dihydropyridine calcium channel blocker. Okay, so this non-dihydropyridine calcium channel blocker like diltiazem and verapamil, it is having effect on vascular smooth muscle and cardiac muscle. Both area it is having effect in the vascular smooth muscle and cardiac muscle. So it is affecting the heart. Non-dihydropyridine calcium channel blocker is affecting the heart. That will reduce the force of contraction. That will reduce the heart rate. So this interaction is more serious. Okay. And this dihydropyridine calcium channel blockers, it is having effect on only vascular smooth muscle. There is no effect on cardiac muscle. So this dihydropyridine calcium channel blocker is not affecting the heart. So their interaction is not that much serious. It is interacting. This diltiazem is interacting with all these four drugs, but more serious interaction is with verapamil as it belongs to same class of drug. Next question, which of the following anti-epileptic drug is given through intranasal route? Midazolam, diazepam, clobazam, nitazepam, which is given by intranasal route. Option A, midazolam is the correct answer. Midazolam, this benzodiazepine, it is a benzodiazepine. For the emergency treatment, it is given by intranasal. It will produce fast absorption or fast onset of action. So this midazolam, it is given by intranasal, intravenous and intramuscular administration is possible for this midazolam. Okay. In case of diazepam, IV is given, oral is given, and rectal administration is possible for diazepam. In case of clobazam and nitazepam, only oral administration is possible. Okay, so intranasal as this midazolam. Next question. The term antibiotic stewardship refers to A. The responsible use of antibiotic to reduce resistance. B. Educating patients on antibiotic usage. C. Developing new antibiotics. D. Prescribing antibiotics for all infection to ensure quick recovery. So what is antibiotic stewardship? Antibiotic stewardship means A. Responsible use of antibiotic to reduce resistance. It is mainly promoting the appropriate use of antibiotics. Mainly, the aim or the goal is optimize the treatment of infection. Only prescribe the antibiotic when it is necessary and for the correct duration and correct dose. If we are not using this antibiotic properly, there can be formation of resistance. There will be resistance if we are not properly using the antibiotic. If we are using antibiotic for all infection, and if it is not correctly used, or if it is not used for the correct duration, the resistance will be occurring. So in order to reduce the resistance, the antibiotic should be used at a proper dose and proper duration. So for optimizing this antibiotic treatment, it is called antibiotic stewardship. Okay, so it will reduce the resistance. So the term that is related to this reduction of the resistance and proper use of antibiotic is antibiotic stewardship. Next question. Which of the following drug is known to cause brown-pink skin discoloration? Which drug side effect is brown-pink skin discoloration? Griseofulvin, dutasteride, clofazimine, clomiphene. Which one can cause brown-pink skin discoloration? Which one is the answer?
Ma'am, option C, clofazimine.
Yes, option C, clofazimine is the correct answer. Clofazimine is a drug that is belong to which class? For treating which condition we are using clofazimine? Leprosy. Yes, leprosy. It is an antimicrobial and it is having anti-inflammatory effect used for the treatment of leprosy. Okay, so this drug is causing brown-pink skin discoloration. The drug can accumulate in the skin and it is interacting with the skin pigment and it can cause brown-pink skin discoloration. So it is the side effect of clofazimine. Okay, we are having some named side effects, that is gray baby syndrome. It is caused by chloramphenicol. Gray man syndrome or blue-gray skin discoloration. It is caused by amiodarone. Red man syndrome is caused by vancomycin. Brown-pink skin discoloration. It is caused by clofazimine. Purple glove syndrome caused by phenytoin. Hand foot syndrome caused by capecitabine. Purple toe syndrome caused by warfarin. Okay, so you have to study these named syndromes. Next question. Which of the anti-diarrhea drug cause black tongue? Which one is causing black tongue? Loperamide, bismuth subsalicylate, diphenoxylate, atropine. Which one is causing black tongue? The correct answer is option B, bismuth subsalicylate. So this bismuth subsalicylate that will interact with the traces of sulfur that is present in the GIT and mouth, and it will form bismuth sulfate. So that bismuth sulfate is responsible for producing this black tongue color or black tongue or black stool. It is caused by the bismuth sulfate and it is a effect. Once this drug is discontinued, this effect can be reversed. Okay, so it is a temporary effect. Once it is discontinued, once the treatment is stopped, this color will be resolved. Okay, so the bismuth subsalicylate will react with the sulfur that is present in the GIT and can cause black stool. Okay, and this condition is a temporary and resolve after discontinuing the medication. A patient with absent epilepsy and the physician increased her valproate dose and because she had a seizure. The goal of the treatment is zero seizure, decrease seizure by 20%, decrease seizure by 50%, decrease seizure by 75%. So what is the goal of treatment if the physician increase the dose because of the seizure? What is the goal of the treatment? Is it to decrease the seizure by 25%? Which one?
Option A, ma'am, zero seizures.
Yes, correct. Option A, zero seizure is the correct answer. For an anti-epileptic drug, increasing the dose. The goal of the treatment will be no seizure. Proper, complete control of seizure. That is the goal of the treatment. Not decreasing 25, 50 or 75%. Complete seizure control is the goal of the treatment. So option A, zero seizure is the correct answer. Next question. Which of the following drug is Olympics? A. Fluoxetine, B. furosemide. Which one is banned in Olympics?
Option A, ma'am.
Fluoxetine is not banned in Olympics. Option B. Furosemide is banned in Olympics. Diuretics. Directly causing any directly increasing the performance. It is not a performance enhancing drug, this furosemide. It is masking the presence of other performance enhancing drugs. Okay. So it is not directly enhancing the athletic performance. It will urination and it will mask the other drugs, presence of other drugs. So for that reason, diuretics are banned in Olympics. Okay. Furosemide. So here are some list of drugs that is banned in Olympics. That is stimulants, narcotic analgesics, anabolic agents, that is steroids, peptide hormones, diuretics. These are banned in Olympics. And restricted drugs include corticosteroid, marijuana, alcohol, beta blockers. These are restricted drugs. Okay, here diuretics, furosemide is the correct answer in this question because as it will flush out the traces of other performance enhancing drug, so it is banned. Next question. A passenger sitting next to you in a plane boasts that he was a famous biochemist. He said he carboxylated a sedating antihistamine and now it is only partially sedating and very well known drug in the market. Which drug he is talking about? Hydroxyzine, cetirizine, diphenhydramine, doxylamine. And a sedating drug is carboxylated and it is formed into partially sedating. It is well-known drug in the market. So which is that well-known drug in the market which is partially sedating?
Cetirizine, ma'am.
Yes, option B, cetirizine. It is a second generation antihistamine. It is obtained by carboxylating. Hydroxyzine is a first generation antihistamine, highly sedating. By carboxylating, by hydroxyzine, we can get this cetirizine. Cetirizine is a second generation with partially sedating effect. Okay. So the drug that biochemist was talking about is cetirizine. Next question. Last question is a 32-year-old woman requests an labor pain. She reports that she had an allergic reaction to Novocaine, that is Procaine, at the dentist office. Which of the following local anesthetic would be appropriate for use in an epidural for this patient? Chloroprocaine, mepivacaine, ropivacaine, tetracaine. Which one can be used? The patient is allergic to Procaine. Procaine belongs to which class of local anesthetic? Ester or amide? Local anesthetic, it is divided into ester and amide. So ester local anesthetic example is Procaine. Procaine, chloroprocaine, tetracaine, these are ester local anesthetics. Mepivacaine, ropivacaine, that are amide local anesthetic. So if any patient is having allergic to ester local anesthetic, they should be given with amide local anesthetics. Okay. So in this option, we cannot give chloroprocaine and tetracaine for this patient because the patient is allergic to ester local anesthetic. So this one cannot be given. All the ester local anesthetic will be having a single eye. You can easily identify which one is ester and which one is amide. Ester local anesthetic will be having single eye. Procaine, single eye. Chloroprocaine and tetracaine, single eye will be there. In case of amide local anesthetic, it will be having two eye. Mepivacaine, ropivacaine, dibucaine, all will be having two eyes. Okay. So patient with ester anesthetic allergic reaction should be given with amide anesthetic. So among this option B and C, can given. Here ropivacaine is the correct answer. Ropivacaine is a amide local anesthetic. It is having long duration of action that is commonly given for epidural. And this mepivacaine, it is short duration of action. It is having short duration of action and it can cause toxicity. So it is usually avoided as the epidural. Most commonly given or used is ropivacaine. Okay.